Okay, you would add to that testing and conclusion, but we haven't gotten that far. After this, I will show you, if anybody wants to see testing at this point, we'll pull up the wall and I'll do testing over here and people can still work over here. Okay, so don't interrupt, don't talk, don't panic, just absorb. You will get it down to this, but this way you can see the flow, the pattern of how it's going to work. Okay. An evaluation of the foot and ankle, you begin with history. First of all, my observations are going to make this easier to make a prognosis of. If anybody else saw it, I'd get their opinions and observations as well. I would first find out the mechanism of injury, how it happened, when it happened, was the onset acute or chronic, what their chief complaint is, where their pain is located, the intensity of the pain, the type of pain, what movements increase or decrease the pain, their chief complaint, sensation, sounds, previous injury. And from that, I would move into inspection. In history of the foot and ankle, I'd find out if they were supposed to be wearing any orthotics, bracing, taping, heel lifts, any of those things. Moving into inspection, I would bilaterally compare, looking for swelling, discolorations, deformities, wound scars, how she removed her shoe or sock, if that was important. With swelling, I would look to see if it was local, secondary to a sprain, or general all over the ankle, secondary to a trauma. Looking to see in the normal resting position that her medial malleolus is more anterior and her lateral malleolus is more distal. Inspecting the shoes to see if she has a broken medial counter indicating flat foot, excessive wear on the lateral border, means she would be toeing in, scuff toes for drop foot, absence of creases, such as no toe off, or oblique creases with hallux rigidus. Also looking for any toe or foot abnormalities. Morton's toes, not really an issue here. She doesn't have any overlapping toes. Bunions are not present. Some callus formation. No mallet toe, claw toes. Really no foot abnormalities with this patient. And also inspecting bilaterally comparing her arches, the medial, lateral, and transverse arch. For your sake, you can try to miss it. Okay, moving into palpation. I would bilaterally compare for point tenderness. Also, if there was swelling, and checking temperature, moisture, feeling for any crepitus. And starting with skeletal palpation, we have the first metatarsal phalangeal joint, first metatarsal in ray, first metatarsal cuneiform joint, first cuneiform, navicular tubercle, navicular bone, medial malleolus, medial tubercle of the calcaneus, lateral malleolus, peroneal tubercle, fifth styloid process, cuboid bone, fifth metatarsal and ray, fifth metatarsal phalangeal joint, second, third, fourth metatarsals, second and third cuneiforms. Also, we have the metatarsal heads on planar aspect. On the first metatarsal head are the sesamoid bones. Okay, soft tissue palpation. We have the tibialis posterior tendon, tibialis anterior tendon. The curl your toes for me, curl them. Okay, with the flexor hallucis longus tendon, flexor digitorum longus, the deltoid ligament. Bring your toes up towards you. Extensor hallucis longus tendon, extensor digitorum longus tendon into the muscles. The retinaculum, peroneus longus and brevis tendons. The anterior talofibular ligament, calcaneal fibular ligament, posterior talofibular ligament, anterior tibiofibular ligament. Looking at the plantar aspect, we have the plantar fascia, again palpating for point tenderness. There's no plantar warts here, we don't have to palpate any of those. She has the gastrocnemius muscle and the soleus on the outside, coming into the Achilles tendon with the calcaneal bursa and the retrocalcaneal bursa, palpable only if inflamed. The peroneal retinaculum. And extensor digitorum brevis. Anybody think of anything I'm missing?
Nope, I think you got him.
So, well, I think you covered it all.
I think you got it.
441, 533.
554. 605.
I started a little late.
I just saved my
Did you save it?
intervals.
I didn't stop yet.
Couldn't figure out how to work my camera.
Sucks.
So I have like
Wait, so that's it? That's all?
Mine only does 15.
She doesn't have
And
Morton's
cut.
toe, so I didn't have to go into Morton's neuroma.
Everybody's on camera.
She doesn't have any bunions, so I didn't
Everybody's
have to
on
look at
camera.
Taylor's.
Everybody's on camera.
And I think I got everything
Everybody's on
else.
Facebook.
From there, okay, from there I would move into testing. The first thing being range of motion. I'll just show you this one for everybody so you can see how this would work. Range of motion, you could do active, passive, and resistive. I'm still like continuing on in the OP mode. And I'm just going to do this motion for her, so it'd be passive. We have dorsiflexion, plantar flexion, inversion, and eversion, abduction of the forefoot, and adduction. Then you have the combination movements of supination and pronation. And we have metatarsal phalangeal flexion, metatarsal phalangeal extension, metatarsal phalangeal abduction, and metatarsal phalangeal adduction. Metatarsal phalangeal flexion is also interphalangeal flexion. So you've got these bending as well as all through here. Okay, and then I'll go into special testing from there. I would do the special tests, and then for my conclusion, I would say in conclusion, I would make a prognosis, refer to a physician to get a diagnosis, correlate the findings with any lab, x-rays, tests that they do, and hopefully she would come back to me for treatment. Okay, but we have that little section in there of the special stability test that I still need to do.
Done.